Good morning, everyone. My name is Michael John Demant. I'm a director of Genoa Underwriting Managers, and I would like to take the opportunity to welcome all of the doctors to the event this morning. Thank you for joining us and giving up your time on a Saturday. I have the pleasure today to introduce people to the event. The first will be Dr. Brad Byrer, who will be addressing us today on telemedicine. I've heard Brad multiple times, and I'm sure that everyone is really going to enjoy what he has to present to us over the course of the next hour and a bit. Underwriting Managers, as many of you in the room will know, is a liability-focused underwriting management agency. We won't insure your house, your car, your mother-in-law, and instead, all that we focus on is professional indemnity for professionals like yourselves. We've got a very well-established book of attorneys, liquidators, business rescue practitioners, and of course, medical practitioners. And some of the more notable and larger PI policies that we've placed in the last few weeks and months are those of Edcon, Group 5, and South African Airways. We have a very specialist team in the medical malpractice space, and we look forward to engaging with you over the course of the next hour and a half. Before Dr. Byrer kicks off, I would also like to introduce Tumi and Nkosi of Vulindlela. Tumi, I'm going to hand over to you just to introduce yourself. We are very proud to be offering this CPD event in participation with Vulindlela.
Good morning, colleagues. Can you hear me?
We can.
Yes, we can. Morning.
All right, good morning, and thanks, Michael. Indeed, it is a great pleasure to welcome you this morning, and once again, thank you for making the time to join us this morning. My name is Tumi Nkosi. I work for Vulindlela Financial Services, and we've really partnered with Genoa to bring you this CPD events, and I'm sure there's going to be many, many more of these kinds of events partnering with Genoa. So I'm not going to go into the product, but essentially we offer short-term and therefore personal cover as well. So we've partnered with Genoa to do that. So enjoy the speaker, and we'll chat later. Thank you.
Thank you.
All right, the final person that I'd like to introduce is a name that I'm sure a lot of you also know, Maxwell Ndlovu of MD Connexions. Maxwell, I don't know if you just want to thank all the attendees or mention anything from your side, after which we'll hand over to Brad to kick off. All right, I think we might be having some technical difficulties from Maxwell's side. So yeah. With that said, Brad, can we hand over to you? Let me just make sure that you are able to share your screen. You should be able to now share your presentation, Brad.
Fantastic. Morning, everyone, and happy Saturday. I don't know about all of you, but I'm in Western Cape today, and it's frosty with a promise of rain, which if you're in the Cape is something that everyone loves. What we're going to do today is go through a presentation that speaks specifically on telehealth and telemedicine. And because we're doing this in a manner that is so far removed, and I say it's far removed because I've had the pleasure of working with Tumi Maxwell before, where it's been a 2.5-hour drive to get to the venue to do an hour's presentation, to do a 2.5-hour drive back. So it's kind of nice to telecommute in this case, and just be close to you without any of us having to get in a car. Of course, the downside is you don't always get to hang out and network and spend time with each other. So just some of the lessons I've learned on these kind of presentations is keep your microphones on mute, because every now and then a child runs through, or I've often apologized for the need to have a CAT scan because the cat's jumped on the keyboard. Equally, I think what's good is if you've got a question that you'd like an answer to, put it on the chat. I'll be able to see it in real time, and then I'll be able to respond to you and to everyone else on questions that we've got as we go through. So the purpose of today is to talk about telehealth and telemedicine from both a clinical application and practical application perspective. I want to do this in a couple of parts by first giving you some context into what is telehealth and telemedicine globally, then go into the regulations and the infrastructures around that, and then talk about it locally, sharing some lessons learned, and then looking at some trends where I think the telehealth and telemedicine will go over the next couple of years. And in doing so, maybe just touch on and answer some of your questions and share some of the experiences we've had. So I hope that's all good with you. I see that there's no questions at the moment. So if you're all okay with that, let's kick off. Kicking off is in theory. One of the first times I traveled to do one of these talks, I got to where I was going. I was on a 3-week trip, and I opened up my laptop screen, and it was just this very beautiful shade of blue. And the colleague I was with looked at it and said, "Oh, it's the blue screen of death." And everything else we did after that was on pen and paper because it just didn't work. I can also tell you at 1 o'clock this morning, I was up writing my patient notes from patients I saw earlier on in the day yesterday. And midway through one of the notes, the system went down and then I had to restart the note. So telemedicine includes how we use our digital platforms, which includes how we use our electronic medical records and the devices that go together. And so I share with you on the difference between medicine and health, and the declaration from the World Health Organization that health is a state of complete physical, mental, and social well-being, not just the absence of disease and infirmity. Now, we all know this, but what does that mean when we start looking at how we apply our acumen or our mind or our clinical approach to a consultation? So how do we define a consultation? And I'm asking these as introspective questions for you as we go forward, because how you define a consultation on a face-to-face basis defines in some ways or informs how you're going to run your consultation on a remote basis. Now, on that would include your visual assessment of the person when they arrive, your initial impressions of that person. It may include the clothing that they wear, their general sense of hygiene. Now, how would you assess a general sense of hygiene during a virtual consultation? So the second question is, can a virtual consultation be part of value-based care? And then the question is, well, how do you define value-based care? What do you regard as being key? And how do you then use that with other people? And that's the third question, is telehealth person-centric? And there's 3 people involved in this. There's the patient themselves, and by extension, their immediate family. There's yourself, and by extension, your practice. And then there's your colleagues, and by extension, the referral practice, as you start to work as an integrated or an interoperable team in order to make sure that help is provided. You'll see on the side of the screen there is a picture, and this picture used with permission, and all the images that I'm going to be sharing with you are used with permission. But this is of a rural healthcare in an area that takes 2 hours to drive to. Suddenly, while it's taking 2 hours to drive to, we can do ultrasonography. We can share it with our colleagues in real time using a connection to our handset and either online or offline data. And then we can share it remotely with other colleagues to get real-time opinions. Now, the real-time opinion and the sharing with colleagues is traditionally or historically in this country what we would call telemedicine. And the doing it in our own place between ourselves and a patient would be what under the HPCSA definitions we would regard as telehealth. I'd also like to spend a little bit of time talking about medical devices and the interoperable tools of what we use and how we use them. So that's the context as we go through. We certainly live in changing times. And for those of you that don't know all of these examples on the screen, I'd like you to take some time if you wanted to and go and look them up. So Google has DeepMind and IBM has something called Watson Health. Nowadays, you'll also have Alexa if you're with Amazon. Babylon Health and Your MD is an artificial intelligence-based smart learning tool where you've got chatbots that have algorithms that follow scripts that assist with triage and diagnosis, including medication reminders and appointment scheduling that the National Health System in the UK had been using. SimSensei is a face and voice recognition tool for diagnosis. Helix is a machine learning that allows response to verbal questions, and those are the front end of a consultation or a diagnostic journey. And then others doing robotic surgery, diagnosing heart problems. I worked and spent really interesting time with colleagues at Constantiaberg Hospital at some stage. One of the neurosurgeons, they said, why do we still use a stethoscope? We've got so much technology now that we can apply to the patient that we don't need to rely on the air conduction between the diaphragm and our tympanic membrane. And so you've now got smart watches and smart devices that allow us to measure all of this. And I think as we go down into general medicine and talk about general medicine in terms of telehealth, one of the questions is, well, how does it all hang together and how long has it all been going on? So there are a host of international guidelines and regulations that speak to how we work. And they're based largely off a set of guidelines, which is now going into its 14th year, called the Continuous Design Guidelines. And those guidelines give a framework of the relationship between a device that we would use, and I'll give you some examples, and the record keeping that we use, and then how we share that data. So if one were to think back, and I can't think back too far because I'm still young, but I saw my first patients in 1991 as an undergraduate. I remember I had a mercury sphygmomanometer and I had a stethoscope, and you would take your blood pressure that way, or not your blood pressure, but a patient's blood pressure, and you'd pump it up and you'd feel for the pulse and you'd auscultate, and then you'd get a blood pressure. Nowadays, you can get a device that's the size of one's thumb that does your SpO2, it does your pulse oximetry, and it does your blood pressure for you. Now, that then can speak to your handset, and that handset can speak to a structure in the clouds. And the way that all of that happens, what I call the handshakes between the device and the patient, and then the device with the patient's data and different storage, is using a technology called Fast Healthcare Interoperability Resources, or FHIR. And I'll show you a picture on the next slide of how that hangs together. Now, that is governed or largely informed by a group called the Personal Connected Health Alliance, and overseen by another group called the Integrating Healthcare Enterprise. So this has all been going on since the very early 1990s. So those of you that have been in practice and you're still figuring it out like me, I'm only in my 27th year in practice this year. One tends to realize that as long as we've been in practice, and possibly longer, there have been medical devices speaking to each other and speaking to ourselves. This has become such a big deal that a series of new acts has come through. But the first act was called the Health Insurance Portability and Accountability Act. And that was what was called the HIPAA Act in the North America, USA from 1996, where your patient's data had to be prepared and stored in a way that when they asked for it, they could have it. And that includes your clinical notes, but it also includes traces and ECGs or EEGs, blood results, PAT results. And so how we record that, how we store that, how we transmit that, and how we share that becomes important. This then became formalized into an act called the 21st Century Cures Act in the USA. The Global Digital Healthcare Partnership was established, and in the European Union, the General Data Protection Regulations came through. In Canada, the Personal Information Protection and Electronic Data Act came through, and all of these relate to how we manage our telehealth and telemedicine engagements with our patients. So you could probably see from this engage that whilst for us we talk about can we get the patient onto WhatsApp or Zoom or Skype or Microsoft or any other virtual platform in order to talk to them, there's a whole lot of information that sits behind it. And to give you a sense of what that looks like, if you look to the left of the screen into the green block, you've got what are called X73 devices or smart devices. Now, these are your personal health devices. Now, when we say your personal health devices, it's a personal health device that you as an individual use, like a smartphone or a smartwatch or a smart scale. I remember when I first was introduced to this was through the University of California, Berkeley School of Public Health back in 2004. And there with a health system called Kaiser Permanente, they were measuring diabetes compliance using smart scales that would then email the information through. I got a note that says they've got that one of our listeners has no sound from me. Is that true for everyone? Because as far as I can tell, the sound is good, and
sound is working perfectly my side, Brad.
Okay, thanks. So Marlene, you may just need to check your sound settings for that. But this is an example. You may find that in the middle of what you're doing, there's one party to your health party who doesn't have access in its full and complete way. So what happened with Kaiser Permanente with their diabetes management system, you would use your glucometer and you would use your scale, and they would Bluetooth and talk to each other. And then that would be sent via email to the doctor, who could see that the patient's weight was tracking and that their glucose was tracking in the way that it should be, and their insulin levels were adjusted accordingly. Nowadays, we can do that. Instead of wearing a halter, you can wear your watch, and it can give you your blood pressure, and it can give you your pulse rate, and it can run a tracer for you. So the world has changed significantly, whether you're using a patient monitoring device, whether you're using a smart tool. In order for that to go through into personal health gateways, and personal health gateways could be your exercise gateway, but it could also be your clinical gateway if you're collecting services. That goes into one set of databases that do what are called IPAs. That means that they handshake or speak to each other on a systems interface, and ultimately that leads into your healthcare information system. Now, that could be a hospital healthcare information system. It could be a health funder healthcare information system. It could be a health community information system where your clinical record speaks to other people's clinical records. And once you get into that phase, you've got to go right the way back into the original interface to say, have I got and been given consent by my patient to store their data digitally and share it with other persons who are not their primary healthcare provider? So when we start talking about this, we then kick into the HPCSA's booklets and guidelines on record keeping, on patient confidentiality, and we're going to talk about that a bit now. But this should give you a little bit of an insight into where we go. So what do our guidelines and regulations look like? And the picture that I've got on the right-hand side of the screen was meaningful for me because there's also tele-rehabilitation, where occupational therapists, physiotherapists, and post-surgical groups are using telemedicine and telehealth as a mechanism of providing rehabilitation. Now, there's some challenges to that in terms of how one would feel or feel resistance or feel muscle strength or feel joint integrity. But on the other side of that, this has been done very successfully in countries for the last 15 years. So in our case, we're informed firstly by the National Health Act, then we're informed by the Health Professions Council ethical guidelines. And I know all of you have downloaded the entire booklet, which is 334 pages, which includes all the booklets. But in this case, we're talking about booklets 1 and 2, 4, 5, 9, and 10, and we're going to go through all of that. There is also a published South African e-health strategy. So mHealth is mobile health, e-health is electronic health, and countrywide, we've adopted a European-centric and US-centric series of focus on how to provide electronic health to members of the public, both in urban centers and peri-urban and remote centers, where the scarcity of practitioners makes sometimes the access to healthcare more of the barrier than it should be. So then I refer in terms of this talk specifically to guidelines on telemedicine that were published on the 9th of March, and the guidance and the changes to telemedicine to allow for telehealth to be brought into a broader use, which happened on the 17th of April this year, whereby a distinction was drawn between what was purely telemedicine, and we'll discuss that, and what was telehealth, which is a virtual consultation between yourself and a third party. Now, the third piece to that, and I think what is an important piece for us, is we have an act here called the POPI Act, the Protection of Personal Information Act. You can see that it was originally promulgated in 2013, and it came into its full and final effect as of the 1st of July. And a big portion of that is how we recognize what is personal data, including health data, biometric data, and genetic data, and then how we protect that data and how we look after it as custodians and stewards of that data. Because whilst we hold that data, the data belongs to the patient, it's their data. And we need to make sure that we look after it and store it and protect it, and not broadcast it when we share it with colleagues in the appropriate way. So the definitions here in terms of booklet 10 of the Health Professions Council defines telemedicine as the practice of medicine using any form of electronic communication, information technology, or other means. And that could be telephony, or it could be the use of voice over IP like you use when you make internet-based calls. And that's between a healthcare practitioner in one location and a healthcare practitioner in a second location. And that's an important distinction, because when the Healthcare Professions Council considered telehealth in its broadest context, clearly they considered it that I have a patient, I need somebody who has broader experience than mine to give me an interpretation or a second opinion. And so myself with the patient, either present or with permission of the patient, shares the patient's information with a second clinician in a remote place, with the view of firstly thinking about facilitating, improving, or enhancing care, or sharing educational information, and or sharing scientific research. So that would be within the context of South Africa. It involves secured video conferencing, all forms of technology, and we're going to talk about that, because the question is, how do we define the word secure? And then it has to replicate, or at least act in as best a possible way, the same as if you were having a consultation with the patient. Okay, so I say that because it's a challenge. It's a challenge. I was challenged in a talk that we did recently, as last week, where a cardiologist said, well, this is all good and well, but I can't have telehealth where I see my patient remotely, because I need to do a tracer, I need to do a stress ECG, I need to do more detailed examination, and I simply can't do that remotely. And in their case, the definition of telemedicine was more appropriate, because they would say if they had the access, a general practitioner or a colleague in a remote area that didn't have all of the information may share some of that information with them in a manner that they could make a appropriate diagnosis or appropriate clinical input, but to do so remotely. And that's where the Health Professions Council says telemedicine is defined, refers to where information is exchanged electronically, on or offline, formally or informally, and there's a need for a second opinion. Now, I'd like to just pause at that formally or informally component, because I want to talk very briefly about if you share information on a social media platform. So you might have a WhatsApp group, and I know that many of you might use WhatsApp, and you might use WhatsApp in a manner to communicate between yourself and your patients. And if you do, we need to talk about that on a different scale. but you may share some of that information or images of a patient or results on a group. Please understand that if you do so, that is broadcasting, and the patient's information is protected. And unless they've given you express in writing consent to do so, they can take exception to you for sharing that information, even though it's in the form of telemedicine. That formally or informally component becomes quite strict. So in terms of the guidelines, telemedicine and telehealth needs to be compliant with the ethical guidelines. So booklet 10, and I'm recommending that you revert and have a look at these guidelines. Booklet 10 speaks about the practice of telemedicine, and I'm referring you to the amendment subsequent to the 17th of April, and as recently as the middle of last month, that changed and extended the scope of telemedicine to include telehealth. We're going to talk about that in the next slide. There's also booklet 2 that you need to be aware of that talks about the ethical and professional rules of healthcare, of the Health Professions Council, and your responsibilities under booklet 1 as a healthcare practitioner. Then you need to also refer to booklet 4, which is around seeking patients' informed consent, because if you're going to do a telehealth consultation with a patient, you need their consent to do so, in the same way that you would need consent to see them as a patient in your practice on a face-to-face basis. So I have an electronic medical record system, and my system expressly says, before you can make your first consultation with me, you need to tick the boxes of informed consent. My informed consent includes the use of electronic records. It specifically includes commentary on WhatsApp and the use of social media platforms to communicate, and it limits my exposure in terms of social media and telehealth. The third booklet outside of booklet 10 that you need to pay attention to is booklet 5, which talks about confidentiality and protecting and providing information around the patient. So there was a period where you needed to be able to record the entire consultation. Now things are modified, and I'll talk about that. And then booklet 9 talks about the guidelines on how you manage patient records. Now, let's assume, correctly so, that as a registered practitioner in good standing and a practitioner who's paid your annual fees, that you're familiar with those booklets. But in the event that you need a refresher, I would go back and have a read of them. You can download the entire booklet off the Health Professions Council site, or you can send a note to us here and we can share the guidelines for you. So telemedicine and the telehealth amendments is important because initially it was telehealth should be preferably practiced where there's already a relationship between yourself and the patient. Why? Because there's already a sense of knowing and understanding between you and them, and you already have a reasonable, and I don't say excellent, but you already have a reasonable start to understand and recognize whether they are off kilter from where they might have been, or their affect is different, or there's a level of malaise or a level of fatigue or a level of apathy that is different. Now, you can still consult even if you don't have a practitioner-patient relationship, as long as it's done in the best clinical interests of the patient. Now, you'll have to define, and those are the gray phrases, what a best clinical interest of the patient means in terms of the kind of practice that you run. Because we're living in exceptional times right now, and I don't know about all of you, but to my knowledge, there's a significant decrease in patient volumes in both general practice and specialty practices right now. And part of that is because there's been a lockdown, and part of it is because of the level 5 and then level 4 and then level 3 restrictions where people are not traveling or they don't want to travel. And you'll also know, because you've been following the information, back on the first week of May, you had 51 tests for one positive COVID patient, and you've now got 4 tests for one positive COVID patient. So there's a very real concern amongst patients about not coming into a waiting room. And there's a very real concern amongst practitioners about not having patients come into a waiting room. So the consequence of that is the extension of telehealth has been made, but the Health Professions Council has also been quite explicit to say that these extensions are in place until such time as the COVID pandemic has been managed and is considered to be passed, at which time new guidelines will be established. Now, we don't know what those guidelines may or may not look like. So one of the things that you probably need to be cognizant of is if you're re-gearing your practice to be an entirely telehealth, telemedicine practice, you may have to re-gear it again as of the 15th of July, which is currently where the extension of the Disaster Management Act ends, because the initial extent of the emergency and the lockdown went to the 15th of June, and then in a regulatory amendment that happened recently, it was then extended to the 15th of July. So to summarize what I'm saying on the slide is, preferably you should have an established practitioner-patient relationship. If not, it needs to be in the best interest of the patient. And in telepsychology and telepsychiatry, you don't need to have had a pre-existing practitioner-patient relationship. You can charge for your telehealth consultation. You can charge the same amount as you would usually charge. You just have to check with the health funders that you've got preferred provider relationships with, or with the networks that you work in, as to what their reimbursement rates are. And of course, you need to be conscious of over-servicing. So as I've just said to you earlier, the guidance and the updates is as long as the pandemic persists, and we will see changes come through in terms of Section 27 of the Disaster Management Act as it comes through from time to time and as it changes. So I see no questions on the chat line. So either everyone is stunned into tragic silence at the complexity of telehealth, or it's a beautiful Saturday morning and you're nice and relaxed. Usually by this time, there's one or two questions that come through. So as of the 25th of June, as we've discussed, your treatment, your decisions, your recommendations given to the patient, and the information transmitted to them needs to be recorded. You don't have to record the entire consultation, but if you could, and you have a facility or a digital platform that allows you to do so, that's probably your best way of doing it. You should be keeping detailed records of the advice that you give to the patient, as well as the diagnostic information or the case history that you use on which the advice is based. Now, obviously, things that you need to continue, you need to have the patient's name and details. You need to have the time and date and place of the consultation. You need to have the presenting complaint. So as I said to you earlier, you need to be mindful of all of those, the patient record keeping that you need to do in terms of your basic registration requirement. You also need the informed consent from patients that you're going to be doing a telehealth consultation and that you're going to be keeping electronic records as a basis. If you're keeping an electronic record, or if you're keeping a annotated record, and I often smile as I say this because I've transitioned out of pen and paper records from what I did in the 90s and the early 2000s onto an electronic record keeping system. But I've got colleagues who say to me, you'll need to prise my pen from my cold, dead fingers before I move from pen and paper records. There's no prescription that says you have to use electronic records for telehealth, but you do need to understand that you still need to, in the minimum, keep your records for a 6-year period after the last consultation with that patient. So if you're doing telehealth records and you're recording, you need to figure out how to do that in a manner that allows you to keep that. If you're doing a minor, you've got to keep them to their point of majority plus 3 years. If they're a disabled or intellectually disabled person, you need to keep their records for life. And if you're working with employers and you're doing occupational medicine work, you need to keep those records for 20 years. So bear in mind that your responsibilities with telehealth are the same in terms of record keeping, but possibly more complex depending on how you record your clinical experience. So I thought we'd change and say, well, what's happened with telehealth in the last couple of months? And by the last couple of months, I like to imagine what happened pre January 2020, because we're 6 months into this pandemic. This is the 5th pandemic that I've done tracking on, and it's been quite interesting from the sense of this is the first time, and when I read this, I enjoyed it. This is the first time we've got a virus that's got its own social media strategy. And so the information that we've got that's moved across the world in terms of COVID-19 and the number of research papers that are being published on both peer-reviewed and unpeer-reviewed on a variety of different sites is up to 30 papers a day. Now, that significantly changes the information we have, and because it does that, it significantly changes the way that we practice medicine. So one of the questions that was raised, and some of the answers in a recent McKinsey study, was how has McKinsey is a advisory and consultancy business that runs a very strong healthcare advisory and trend arm. And so they've noticed that there was a roughly 11% use of telehealth by patients in 2019. That's now moved up to 76% are now interested in using it going forward. Now, that doesn't mean that 70% of all your consultations will do that, but it does mean that there's a significant amount of your patients who would be willing to use it if the opportunity was there. Because in this study, more than 70% of the face-to-face consultations in rooms were cancelled in the early months as it relates to COVID. Now, a big percentage of people said that they would have had those consultations if they could have done it on a remote basis, like on a telehealth basis. And I don't know about your practices, but if you have a large amount of chronic patients or patients who need to be assessed on a monthly basis for acute and chronic issues, patients with allergies, patients who are possibly pre-diabetic, patients who have mild hypertension as opposed to more acute issues, children who have infections, you still need to run a practice because people will still have morbidities and comorbidities that have nothing to do with COVID. And so the telehealth trends are showing it. From a healthcare practitioner point of view, there has been a massive increase in the number of telehealth visits compared to pre-COVID, but understanding that the number of telehealth visits was relatively small to begin with, so a massive increase in those numbers isn't a dramatic thing, but it does show that there would be a trend, and that trend could significantly change. So you may be asking yourself the question now, well, what should I do? Now, a lot more practitioners are comfortable using telehealth than they were before. Just like a lot of us who would have done presentations or attended CPD presentations always used to do them face-to-face. And my last face-to-face presentation was on the Saturday pre-lockdown. And it was for this group, actually. And we were out in Krugersdorp. And there was 150 odd practitioners in the audience. And one of the things that we were asking and discussing at that presentation, it was a presentation on medical errors in social media. Some of the issues that were raised was, well, what happens now when patients phone in and they say, I've got a fever, should I have a test or should I come in? And the questions that were raised at that time was, well, do you have a telehealth script? Does your nurse or your office manager have a script? Do you have a mechanism of sharing an informed consent form with the patient who wants care remotely? And we're now only 100 days, because it's 100 days now since that day. And you can see the massive shifts that have happened. And this is one example of those big shifts. So AMA is the American Medical Association. They did a digital health consumption or usage study in 2016. And they followed that study up in 2019. And this study, these numbers that I'm sharing with you, and those of you that want any of this information, you're welcome to reach out and we'll share it with you. They published this in February 2020. And they said that since 2016, there were 4 key areas that were relevant where there's been significant change. There is a significant amount of physicians who, and that's primary care practitioners and secondary care practitioners, who are using digital tools. Now, digital tools in this context are medical devices, remote monitoring, telehealth, and telemedicine. Interestingly, there was a small group of people who are over the age of 50 that don't see an advantage of using digital tools, and some of that is the delay in adoption of technology by people who are a bit older. I fall into the 50+ segment, although as much as I do try and be tech smart, it was a massive deal for me to buy a wireless printer where I could print from my phone onto the printer without plugging things together. So there's a headspace shift that needs to happen as we move into digital health. The second thing that the AMA study found was that the adoption of digital tools has grown amongst physicians regardless of gender, specialty, or age. So tools used for remote monitoring, when they talk about 7 tools, those are tools around remote access, patient monitoring, teleconsultation specifically. But they also realized that there were some drivers, and we're going to discuss them on the next couple of slides, but efficiency and patient safety were key drivers. And they also, practitioners, yourselves, myself, need to know that our medical indemnity insurance covers the use of these devices and that we've addressed issues on data privacy. Now, one of the big data privacy issues, and we speak about this in a different forum, but I'll just mention it here, is the risk of having your records hacked. Now, one of the current sports amongst cyber criminals or digital criminals is hacking into practitioners' files or hospitals' files and taking patient data. Now, there's no harm to the patient unless that information is used in a way that directly prejudices them, but it does cause anxiety, and it also challenges the issue on how safely we manage our patient information. So my question for you is, if you've got patient information systems, do you have the right passwords? Do you have the right levels of authentication to make sure that you are looking after the information? The third piece there is the adoption of the remote care tools. Televisiting and remote monitoring has seen the most increase since 2016. Remember, this was pre-COVID, so you could appreciate that post-COVID, this will increase significantly. And there's a lot more information around about artificial or augmented intelligence, like the information I shared with you in the beginning slide on how many more tools there are that can look at patterns of cardiac rhythms or arrhythmias, atrial fibrillation, ventral fibrillation, trends on insulin and diabetic risks, and so on. So this is an example of the perception that practitioners and patients have in terms of televisits, or what they call virtual visits. You'll see under current state, there's a curve there. Now that curve is called the diffusion of innovation curve, and it was written by a guy called Everett Rogers, or promoted by Everett Rogers in 1984. So as much as we're talking about things now in 2020, 1984 takes us a while back, and we see that the mechanism of how we do things hasn't significantly changed. What's interesting around televisits is the most attractive elements of this is it improves patient convenience and work efficiency. And part of that is it allows you to run your practice to time. It allows you to manage delays better. It takes away the patient's need to commute. And it also takes away the intensity of meeting other potentially contagious persons in a waiting room. And that allows a larger degree of patient safety. There is a sense that it improves the patient-doctor relationship, and maybe it does so because there is a reduced sense of the patient-doctor dynamic, the power dynamic, because now you're talking to me and I'm in my house. You're in your practice and I'm in my house. Whereas before, we're in your practice, in your rooms, and there's a lot of patients who feel like there's a disequilibrium of control there, and that's where the patient-doctor relationship comes from. It also increases and improves the stream of revenue for patients who wouldn't ordinarily be able to come and see you. Now they can. The key requirements is that it needed to be covered by medical indemnity in the event that things went wrong. and to understand you can only have your elements of practice covered or protected by your indemnity, which is your deferred risk, if you're following the guidelines and doing as the reasonable practitioner would do. If you're posting a patient's information on a social media forum and you're not behaving like the reasonable person and the reasonable practitioner, you're less likely to be able to defend your position. One of the key requirements is you can be reimbursed, and we spoke about that earlier. And whilst they say there that it doesn't require special training, just like when you did your first case history, it was one thing being able to know that you did a general history, and then you did a specific condition history, and then you did a medical history, and then you did a family history. It's a rhythm and a technique that you follow to get good at doing that case history or that physical exam. And it's the same in a telehealth consultation. It takes a degree of practice to get it smooth. It may or may not be well integrated with your electronic health record, depending on what platform you're using. Now, they do say there it's as good as traditional care, and you'll recall that I asked you at the beginning of this discussion, what defines for you a consultation? And if you can say that your consultation remotely is as good as your consultation face-to-face, it can be as good as. If there are elements of your practice that you would still need physical touch for, you then need special training, and you need to train your patient in terms of how you do your consultation to make sure that you're getting the right kind of support and or providing the right kind of consultation. So here you can see remote monitoring, and remote monitoring would look at things like hypertension. It would look at things like diabetes. So you'll see their weight, blood pressure, blood glucose, and the readings are available to the patient, and they come through to your office on your smart device using the technology that we spoke about in the very early slides. And here the top three issues are patient safety, patient adherence and compliance, and diagnostic ability as being the best, most attractive elements of remote monitoring. And remote monitoring is part of telehealth. The components of this that you'll need to have a look at is the provision of remote care and the maintenance of the patient-doctor relationship, because I think those are important things. So then I wanted to share with you a case study of how this has been working in other countries, and does it work. So in Portugal, they have a national telehealth plan where the patient is the center of the plan. And I take you back to the first slide where I said, is this valuable? Is your telehealth consultation defined? Do you have a script for it? Is it structured? Is it part of value-based care where the patient gets the value for the fee that they spend? And is it interoperable? Can you share this with other persons who are integral in the patient's healthcare journey? Now, Portugal's been doing telehealth since the 1990s. They have a plan called PENS, which is their National Strategic Telehealth Plan. You heard me talk about the fact that we have an EHEALTH plan that was a 2012 to 2019 plan. They also do telemonitoring, and with telemonitoring, that includes telerehabilitation, but it also includes the self-service platform where the patient can use the electronic record to make an appointment, to send you a query, to send you a note, to send you their information. It also allows for e-prescription management. And e-prescription management is quite important. We have a very, very good series of tools in this country. One of my pleasures is I do some lectures that are static-based lectures on medication errors and medication health. One of the people who is a co-presenter with me runs a e-prescription and call it a remote pharmacy fulfillment program, where if you go to certain filling stations, you go into their convenience stores, there's a vending device there where you can buy over-the-counter medicines, you can buy headache pills, or you can buy antiemetics, and you can buy contraceptions and so on. So in the same way, using the same kind of technology in peri-urban and remote areas, your prescription can be loaded into a booth that you have the biometric access to. That booth logs then the time that it takes from when the medicine is loaded to when the patient removes that medicine. And then it logs whether they are coming on a regular enough basis, which then gives both the pharmacist and the practitioner an idea whether there's adherence and compliance to the medication regime that's on. For us, in terms of diabetes, in terms of TB, in terms of HIV, and in terms of other chronic care, like hypertensive care, these could be very, very important triggers on patient compliance and potential patient risk. So into that, they also in Portugal do teletriage, telecare, and provide health information through what they call their My SNS, their criteria, which is a data wallet that they can take from patient to from practitioner to practitioner, where their entire medical record is kept on a card-sized, credit card-sized smart card. Interestingly, in Portugal, because they want to decongest the risk of practitioners' waiting rooms, they want to limit the amount of transport of vulnerable or at-risk or unhealthy people to and from consultation, the practitioners get paid an additional 10% for teleconsultation than they would get paid for face-to-face consultation. So here are some current challenges by country or region that was also done by McKinsey, looking at the European Union. The key things that come out of this slide that I think are important for us, one of them is the resistance of clinical staff to use this. The second is the amount of sufficiently skilled employees. And you'll see on 4 of the countries, and if you add the resistance of staff, 6 of the countries have a challenge as it relates to the sense that either the practitioner or the practitioner's assistant or the office assistant or the paramedical support staff don't feel either that they have enough skill or they have enough training or they have enough confidence in the tools to be able to use them. The second piece to that, which is important, is the funding. Do we have enough funding, and do we have enough interoperable standards that allow us to share the information between countries? So when we look at that in terms of connecting care priorities and trends, and we look at what's potentially coming here, because we would compare what's coming here to what's going on in the rest of the world. In the rest of the world, you'll notice that the use of patient-generated data, the use of electronic medical records, the use of system usability all goes together. If you don't have the right systems, and you don't have electronic records, and you don't have good patient data, it's very, very difficult to provide good e-health or good digital health, which makes the use of telemedicine on a singular basis sometimes practical, but on a broader basis, there's potential barriers. And I think the biggest thing for us, given what's happened with the hacking of personal information over the last periods of time, is IT security. Can you protect the information off the data that you're doing? So the top trends that we're going to see in time to come, and I think this is roughly where we're going to end up so that we can ask or answer some questions. The first is the provision of telemedicine and telehealth by providers. And this relates very specifically also to your use of technology in your practice, because the more your practice is geared towards technology, the more effectively you can provide both telemedicine, which includes 2 practitioners and a patient, and telehealth, which is yourself as a practitioner with a singular patient. That then speaks directly to the personal health records that you're keeping and your patient's access to those same records so that they can add information in preparation for a telehealth consultation. And then, of course, one of the big trends to come, and we're already seeing it, and you saw that on the second slide that I shared with you, is the use of artificial intelligence, of scripting, of voice recognition, on face recognition to triage, so that by the time the patient comes to you, there's already a sense in your mind of what that looks like. Now, your question would be, and my question to you is, how would you do your vital signs? How would you take a temperature? How do you take a blood pressure? How do you assess the pulse? how do you feel the skin if you're worried about a fever? So I don't have the answers to a lot of these, but these are the HIMSS insights that were published in December this year. And at that takes us to just short of the hour, which is where I like to stop to allow us to have a discussion. So MJ, I'm going to hand over to yourself, Maxwell, and to me to say, how can I help and answer any questions that anyone might have?
Thank you, Brad, for a very informative talk. Doctors, for those of you that are new to the Zoom platform, there has been a chat function that's been going on the right-hand side. I don't know if any of you have got questions for Brad, but there are two ways that you can go about doing this. The first is you can write those questions in the chat box, as Brad suggested a little bit earlier. Alternatively, if you would prefer to speak through the question, you just need to hold down your space bar on your laptop, and that will automatically demute you, and you'll be able to raise the question yourself. I'm going to hand over or back to the floor, and if anyone does have any questions, then please utilize the time now to address Dr. Bara.
Good day, are you able to hear me?
We are, Doctor.
It's Jack van Ifrik. I'd just like to know, for a 50 plus individual with no IT technology expertise, how one would install one or other form of telemedicine in one's practice. Are there practitioners that do that? Or do you have to fumble your way through the system, which won't work for me? Thanks.
So Jack, as a 50 plus technophobe, I'm not a fan of technology, and I'm always a late adopter. What I found is if this is something that you want to do, getting the right tools and technology means that you need to get help from somebody who does this for a living. So there are a wide variety of technology suppliers, and if you like, I can identify one or two, and we can share that information with you. But really what you want to do is you want to be able to have somebody come in and look with you at what the best solution could be. Whether you need a good video camera on your side, whether you need large storage, whether you need, and what platform you want to use. Some of them are for free. And for example, the one that we're using now, you can use for free for up to 40 to 45 minutes per consultation. If you're using WhatsApp, there is a WhatsApp business function where you can use a WhatsApp a video consultation. There's Skype, there's Starleaf, there's BlueJeans, there's many. So the suggestion would be, don't fumble it alone. If you're going to do this, reach out to a technology partner or a grandchild who usually knows which technologies are the best, and then invest a little bit of money in setting it up properly.
Would you be able to give me a specific one of these organizations that I can call on to come and set it up at my consulting rooms?
Yeah, if you give me a couple of days, I'll put together a list of those that I think are reasonable, and I'll share them through Genoa, and they can share that list out.
Thank you. Thank you.
Pleasure.
Doctors, anyone else got any other questions for Dr. Bara? Remember, you just hold down spacebar to address them. If not, then we will bring the presentation to a close. Representatives from Vulindlela Financial Services will be in touch with you in the coming days to arrange the delivery of your CPD certificates. Belinda, yes, we'll make the list available to all attendees so that you know which are the best platforms to utilize for telemedicine. Marlene, I hope you were able to get your sound sorted. I see that you stayed in, so I'm assuming you did. Okay, last 30 seconds. Anyone have any other questions? Alternatively, we'll bring the meeting to a close, as I say.
Just to say thank you very much and very informative.
No problem at all, Dr. Niftrick. All right, Brad, I think you obviously addressed everyone's questions, comments, and any concerns that anyone did have. Doctors, have a fantastic Saturday, and thank you again for taking the time to join MD or at MD Vulindlela and Genoa Underwriting Managers. All righty, I'm going to be signing off. Brad, again, thank you for your time.
Thanks,
Thanks, everyone. Bye.
Thanks, Jimmy.
Thank you. Cheers, man.